Hello, it's Jihad Ali from Coronary University, and the course is Concept of Human Physiology, and is supervised by Dr. John Tayson. And today we are going to talk about the cardiac 2 and blood presentation. So without further ado, let's get started. In this slide, I'm going to talk about the cardiac output and autonomic nervous system influences. So what is cardiac output? It is the volume of blood pumped by each ventricle per minute, not the total amount of blood pumped by the heart. During any period, the volume of blood flowing through the pulmonary circulation is the same as the volume flowing through the systemic circulation. Therefore, the cardiac output from each ventricle normally is the same. There are two factors affect on cardiac output, which are heart rate, which is mean beats per minute, and the stroke volume, which is the volume of blood pumped per beat or stroke. The average resting heart rate is 70 beats per minute, established by sinoarterial node erythrocytes. The average resting stroke volume is 70 milliliter per minute, producing the average cardiac output of almost 5 liters per minute. Autonomic nervous system influences on cardiac output. The heart is innervated by two divisions of autonomic nervous system: sympathetic and parasympathetic nervous system, which can modify the rate and the strength of the contraction, even though nervous stimulation is not required to initiate contractions. They act by altering the activity of cyclic adenosine monophosphate, second messenger pathway in the innervated cardiac cells. Cardiac parasympathetic nerve to the heart through the vagus nerve primarily supply the atrium, especially the sinoarterial node and arterioventricular node. Parasympathetic innervation of the ventricle is sparse, on the other hand, while the cardiac sympathetic nerve supplied the arteria, including sinoarterial node and arterioventricular nodes, and richly innervated the ventricles. Acetylcholine released from the vagus nerve binds to the muscarinic cholinergic receptor and is coupled to an inhibitory G protein that reduces the activity of the cyclic adenosine monophosphate. By contrast, the sympathetic neurotransmitter norepinephrine binds with the beta-1 adrenergic receptor and is coupled to stimulatory G protein that accelerates the cyclic adenosine monophosphate in the target cells. For example, in sinoarterial node, the effect of parasympathetic stimulation decreases the rate of depolarization to threshold and decrease the heart rate, while in arterioventricular node decrease the excitability and increase arterioventricular node delay. In sinoarterial node, the effect of parasympathetic stimulation increase the rate of depolarization to threshold and increase the heart, while in arterioventricular node increase excitability and decreases the arterioventricular node delay. In this slide, I'm going to talk about the Frank-Starling law of the heart. The main determinant of the cardiac muscle fiber length is the degree of diastolic filling. So if we take an example analogy of a balloon filled with the water, the more water you put in, the larger the balloon becomes, and the more it stretches. Likewise, the greater the diastolic filling, the larger the end diastolic volume, and the more the heart stretch. The more the heart stretch, the longer the cardiac fibers before contraction. The increased length result is a greater force on the subsequent cardiac contraction, and thus is a greater instotic volume. The intrinsic relationship between end diastolic volume and stroke volume is known as the Frank-Starling law of the heart. Stated simply, the law says that the heart normally pumps out during diastole the volume of blood returning to it during diastole. An increased venous return results in an increased stroke volume. The built-in relationship matching stroke volume with the venous return has two important advantages. First one is the intrinsic mechanism equalizes output between the right and the left side of the heart. Also, that the blood pumped out by the heart is equally distributed between the pulmonary and systemic circulations. Although the length and tension relationship in cardiac muscle fiber depend on to a degree to the extent of overlap of thick and thin filament, similar to the length tension relationship in skeletal muscles, the key factor relating cardiac muscle fiber length to tension development is the dependence of myofilament calcium sensitivity on the fiber length, specifically as the cardiac muscle fiber is stretched as a result of greater ventricular filling its myofilaments are pulled together close side by side. As a result of this reduction in the distance between the thick and thin filaments, more cross-bridges contraction between myosin and actin can take place when calcium pulls the tropomyosin complex away from the actin cross-bridge binding sites. That is, myofilament calcium sensitivity increases. Thus, the length tension relationship in cardiac muscles depend not on muscle fibers per se, but on the resultant variation on the lateral spacing between myosin and actin filaments. Coronary artery disease and the determining factor involve the reduction of blood flow to the heart muscle due to buildup of atherosclerotic plaque in the arteries of the heart. It is the most common of the cardiovascular disease. Types include stable angina, unstable angina, myocardial infarctions, and sudden cardiac death. A common symptom is a chest pain or discomfort which may travel into the shoulders, arm, back, neck, or jaw. Occasionally, it may feel like heartburn. Usual symptoms occur with the exercise or emotional stress, less than a few minutes, and improve with the rest. Shortness of breath may also occur, and sometimes no symptoms are present. In many cases, the first signs is a heart attack. Other complications include heart failure or abnormal heartbeat. Risk factors include high blood pressure, smoking, diabetes, lack of exercise, obesity, high blood cholesterol, poor diet, depression, and excessive alcohol consumption. In this slide, I'm going to talk about the pressure gradient, resistance, and blood flow. So the flow rate of the blood through the vessels, that is the volume of blood passing through per unit of time, while the pressure gradient is the differences in pressure between the beginning and at the end of the vessels, while the vesicular resistance is the measure of hindrance or resistance to blood flow through the vessels, caused by a frictional between the moving fluid, which is the blood, and the stationary vesicular wall. The flow rate of the blood is directly proportional to the pressure gradient. As the pressure gradient increases, the flow rate increases, and inversely proportional to the vesicular resistance. So as the resistance increases, the flow rate decreases. A pressure gradient, as I mentioned, is the difference in the pressure between the beginning and the end of the vessels. A blood flow from an area of higher pressure to an area of lower pressure down the pressure gradient. So the contraction of the heart imparts pressure to the blood, which is the main driving force for flow through the vessels. Because of frictional losses, which is mentioned in the resistance, the pressure drops as the blood flow throughout the vessel length. Accordingly, so pressure is higher at the beginning than at the end of the vessel, establishing a pressure gradient for forward flow of the blood through the vessels. The greater the pressure gradient forcing blood through the vessel, the greater the flow rate through the vessels. That is the difference in pressure between the two ends of the vessels, not the absolute pressure within the vessel determine a flow rate. As we see in the figure over here, that the flow rate was 50 at the beginning of the vessels and end up at 10. So the differences the difference between is the pressure gradient, which is 40, while the second vessels the pressure was 90 and the end of the vessel is 10. So the differences in pressure, which is the pressure gradient, is 80. So the flow in the vessels in the second vessels is 2 times higher than that of the first vessels. That's why the flow rate is directly proportional to pressure gradient, while the resistance is the other factor influencing the flow rate through the vessels. Is resistance, which is the measure of the hindrance or opposition to the blood flow, as I mentioned earlier. As resistance to flow increases, it is more difficult for blood to pass through the vessels. So flow rate decreases as long as the pressure gradient remains unchanged. While resistance increases, the pressure gradient must increase. So correspondingly, to maintain the same flow rate, accordingly, when the vessels offer more resistance to flow, the heart must work harder to maintain adequate circulation. Resistance to blood flow is directly proportional to the viscosity of the blood, directly proportional to the vessel length, and inversely proportional to the vessel radius. Arterioles are the main resistance vessels in the vascular tree because their radius is small enough to other considerable resistance to flow. The high degree of arterial resistance causes a marked drop in the mean pressure as the blood flows through these small vessels. On average, the pressures fall from 93 mmg the pressure of the blood entered the artery from the arteries, to 37 mmHg, the pressure of the blood leaving the arterioles and entering the capillaries. The radius and accordingly the resistance of the arterioles supplying individual organ can be adjusted independently to accomplish two functions. Variable distribute the cardiac output among the systemic organ depending on the body momentary needs, and the second one to help regulate arterial blood pressure. Unlike artery, arterioles walls contain little elastic connective tissue. However, they do have a thick layer of small muscles that is richly innervated by sympathetic nerve fibers. Smooth muscles is also sensitive to many local chemical changes, to a few circulating hormones, and to mechanical factors such as stretch. The smooth muscles layer run circularly, as we see in the paragraph, around the arterioles. So when the smooth muscles layer contract, the vessel's circumference and its radius became smaller, increasing resistance and decreasing the flow through that vessels. The effect also of the temperature changes, another local physical influence on the arterioles, can exploit clinically heat application by causing localized arterioles. Vasodilation is a useful therapeutic agent for promoting increased blood flow to an area. Conversely, supplying an aspect to an inflamed area produces vasoconstriction, which reduces swelling by contracting, and also histamine induce vasodilations, and the other hormones that externally influence arterial stones are vasopressin and angiotensin 2. Both vasopressin and angiotensin 2 are potent vasoconstrictors. Their roles in this regard is especially crucial during hemorrhage, a sudden loss of blood, as we know. Reduce the blood volume, which trigger increased secretion of both of those hormones to help restore the blood volume. Their vasoconstriction effect also help maintain blood pressure despite abrupt loss of blood volume. As we see in the paragraph over here, there are too many factors affecting the vasoconstrictions and the vasodilations, as I mentioned earlier. Some of them are mechanical and some of them are chemical. Erythrocytes are flat disc-shaped cells indented in the middle of both sides. The biconcave shape provides a large surface area for diffusion of oxygen from the plasma across the membrane into the erythrocyte. Erythrocytes, I mentioned, are biconcave discs about 8 mm in diameter, which can deform remarkably as they squeeze single cells throughout the capillary, as narrow as 3 mm in diameter. Because they are extremely flexible, red blood cells can travel through the narrow tortuous capillary to deliver their oxygen cargo at the tissue level without rupturing in the process. They are 2 mm thick at the outer edge and 1 mm thick in the center. There are 5 million cells per cubic millimeter. Hemoglobin is found only in red blood cells, and hemoglobin's molecule has two parts in particular. The globin portion, a protein made up of 4 highly folded polypeptide chains. 2 are subunit, 2 are alpha subunit, and 2 are beta subunit, and 4 iron containing nanoprotein groups known as heme groups, each of which is bound to of the polypeptide. Each of those 4 iron atoms can combine reversibly with 1 molecule of oxygen. Thus, each hemoglobin molecule can pick up 4 oxygen passengers in the lungs. Because oxygen is body soluble in the plasma, about 98.5% of the oxygen carried in the blood is bound to hemoglobin. The primary function of erythrocyte is to transport oxygen and to a lesser extent carbon dioxide. We can definitely say there are 4 main blood types: A, B, AB, and O. Each blood type has a different protein marker on the surface of the red blood cells. A transfusion reaction occurs when a person is given blood that has different protein marker than their own. The body identifies the protein marker as a foreign substance, amount, and immune response. This can cause a severe reaction that can lead to death. The ABO blood group system is the most essential blood type system in the human blood transfusion. When a person with a different blood type receives a transfusion of blood, their body sees the foreign protein markers and reacts to them as if they were a threat. This can cause a transfusion reaction which can be mild or severe according to what was mentioned. ABO blood group system is basically determined by the presence or absence of the A and B antigen on the surface of the red blood cells. If the person has the A antigen on their blood cells, they are type B. If a person with a B antigen on their blood cells, they are type B. If a person has both A and B antigen on their blood cells, they are type AB. If a person has neither the A nor B antigen on their blood cells, they are type O. So we can transfer type A blood to the people with type A or O blood. The type B blood could be given to people with either type B or type O blood, while type AB blood is unique. It can be transferred to the people with type AB or type O blood. The type O blood can be transferred to people with type O blood. Type A blood carries A antigen on its red blood cells. People with type B blood have the B antigen on their blood cells. People with type AB have both A and B antigen on their red cells. O blood has no A or B antigen on the red blood cells. So if a person with type A blood receives a transfusion of type B blood, their blood cells will see the B antigen as a foreign invader and will attack the red blood cells. This can cause transfusion reaction, which can be mild or severe, as I mentioned. So if a person with type B blood receives a transfusion of type A blood, their body will see the A antigen as a foreign invader and will attack the red blood cells. This can cause transfusion reaction, which can be mild or severe. If a person's body will see the antigen as a foreign invader, will attack the red blood cells. Blood constituents and their functions. When a sample of blood is spun and centrifuged, the cells and cell fragments are separated from the liquid intracellular matrix. Because the former elements are heavier than the liquid matrix, they are packed in the bottom of the tube by the centrifuge force. The light yellow colored liquid on the top of the plasma, which accounts for about 55% of the blood volume, and red blood cells, is called the hematocrit or packed cells volume. The white blood cells and platelets form a thin white layer called the buffy coat between a plasma and red blood cells. So in a plasma, one of the other constituents is water, act as transport medium and carries heat, while the erythrocytes are important in membrane excitability and distribute fluid by osmosis between extracellular fluid and intracellular fluid, and buffer pH changes, while the nutrients and waste gases hormone are transported in blood. Carbon dioxide play a role in acid-base balance, while plasma protein in plasma in general exert an osmotic effect important in the distribution of extracellular fluid between the vesicular and interstitial compartments, and buffer pH changes, while the albumin transported many substances contribute most to a colloid osmotic pressure. Also, globulin alpha and beta transported many water insoluble substances include clotting factors and inactive precursors molecules, while gamma globulins are antibodies. Fibrinogen is an active precursor for the clot fibrin meshwork. And the other cellular element of the blood is erythrocyte, which transport oxygen and CO2 mainly, while leukocytes play an important role in immunity, and neutrophils engulf bacteria and debris, while eosinophils attack parasite wounds, play a role in allergic reactions. Basophils release histamine, which is important in allergic reactions, and heparin, which help clear fat from the blood. Monocytes also play an important role, are in transit became tissue macrophage. We have also lymphocyte P, which produce antibodies, and T lymphocytes produce cell-mediated immune responses, while the platelets contribute to hemostasis. A clotting pathway includes the creation of fibrin as a blood protein that obtains platelet into a blood clot. Fibrin is produced through two distinctive pathways that converge near the end into common pathway for fibrin formation. A coagulation consists of three pathways: the extrinsic, intrinsic, and common pathway that relate together to form a stable blood clot. As we mentioned, the intrinsic pathway started by the instigation of factor 12 from exposure of collagen due to injury to a vessel wall. As a result, factor 12A catalyzes the activation of factor 11 toward 11A, which in return catalyzes the activation of factor 9. Factor 9A, in addition to factor 8, catalyze factor 10 into the active factor XA, which convert prothrombin into thrombin, leading to catalyzing fibrinogen into fibrin. The second pathway, as I mentioned, is the intrinsic pathway, which is triggered by the disturbances in the vesicular wall. Tissue factors that are bound intracellularly are released during trauma and activate factor 7. Together, the tissue factors and factor 7A help to convert factor 10 into active factor XA. As with the contact activation pathway, activation of factor XA lead to catalyzing of prothrombin into thrombin. The later catalyze fibrinogen into fibrin. And here are my references for the cardiac aspect presentations. Thank you for listening and have a good day.